Diseases of the breast. Q&A. Welcome to today's podcast, where we discuss the main aspects of diseases of the breast. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of diseases of the breast. Pause the podcast after each question to attempt answer. Let's begin. Breast anatomy, development, and physiology. Breast anatomy question. What are the relevant anatomic structures associated with the breast? Answer. The relevant anatomic structures include the breast itself, the chest wall, the axillary region, the internal mammary area, and the supraclavicular region. Question. Where is the breast located in relation to surrounding tissues? Answer. The breast is positioned between the skin, adipose tissue, superficial pectoral fascia, and the pectoralis major muscle. Question. Where is the breast located in relation to the pectoralis major muscle? Answer. The breast is located deep to the pectoralis major muscle and is enclosed within the clavipectoral fascia. Question. What are the suspensory ligaments of Cooper and what is their function? Answer. The suspensory ligaments of Cooper are fibrous bands running between the chest wall and the dermis, and they provide structural support to the breast. Question. What is peau d'orange and what causes it? Answer. Peau d'orange is dimpling of the breast surface, usually caused by edema or cancer infiltration of the suspensory ligaments of Cooper. Question. What is the tissue composition of mature breast tissue? Answer. Mature breast tissue is composed of glandular epithelium, fibrous stroma, and adipose tissue, with the proportions varying at different stages of life. Question. How is the glandular structure of the breast organized? Answer. The glandular apparatus of the breast consists of a branching duct system, arranged radially from the nipple, with 15 to 20 lobes, each ending in a lactiferous duct. Question. What are the milk-forming units in the breast and how are they structured? Answer. The milk-forming units are acini, which are the milk-producing glands. Together with their ducts, they form terminal duct lobular units, also known as lobules, surrounded by specialized connective tissue. Question. What is the structure of the ductal system in the breast? Answer. The ductal system in the breast is lined by epithelial cells, surrounded by myoepithelial cells, and enclosed by a basement membrane. Question. How does breast cancer metastases from the breast tissue? Answer. Breast cancer metastases when two more cells invade the duct wall, allowing access to lymphatic channels and blood vessels. Question. How is lymphatic drainage of the breast primarily accomplished? Answer. Lymphatic drainage of the breast is primarily through the axillary lymph nodes, which account for 70 to 80% of drainage. Minor drainage occurs through the pectoralis muscle and internal mammary lymph nodes. Question. How are axillary lymph node levels classified? Answer. Axillary lymph node levels are classified based on their position relative to the pectoralis minor muscle. Level 1, lateral. Level 2, posterior and anterior. And level 3, medial. Question. What regions does lymphatic drainage in the breast encompass? Answer. Lymphatic drainage encompasses the upper extremity, chest wall, upper abdomen, back, and the breast itself. Question. How does the arm's lymphatic drainage cross the axilla and what clinical implication does this have? Answer. The arm's lymphatic drainage crosses the axilla in various patterns, sometimes reaching several centimeters below the axillary vein. This increases the risk of lymphedema after axillary surgery. Question. What are the surgical boundaries of the breast and axilla? Answer. The surgical boundaries include the serratus anterior and chest wall, medial, latissimus dorsi, teres major, and subscapularis, posterior, pectoralis major and minor, anterior, and the axillary vein, superior. Question. Which nerves are important in breast and axilla anatomy? Answer. Important nerves include the long thoracic nerve, innervates serratus anterior, thoracodorsal nerve, innervates latissimus dorsi, and medial pectoral nerve, innervates pectoralis major. Question. What are the significant neurovascular structures in the breast and axilla? Answer. Significant neurovascular structures include the thoracodorsal nerve and vessels as well as the pectoral neurovascular bundle, which assists in locating the axillary vein. Question. What is the function of the nerves in the axilla and chest wall area? Answer. These nerves provide sensation to the upper inner arm and the skin of the chest wall along the posterior margin of the axilla. Question. What are the surgical implications of dividing nerves during axillary procedures? Answer. Dividing these nerves can result in cutaneous anesthesia and, in rare cases, cause a chronic pain syndrome. Question. Why is nerve preservation important during axillary dissection? Answer. Preserving the most superior nerve ensures arm sensation is maintained without interfering with axillary dissection. Breast development and physiology question. How does the milk line develop and what is its normal outcome? Answer. The milk line extends from the axilla to the inguinal area and normally forms a single pair of breasts. Question. What happens if the milk line does not atrophy completely? Answer. Incomplete atrophy of the milk line can lead to the development of extra breasts, polymastia, and extra nipples, polythelia. Question. What are some anomalies that can occur during breast development? Answer. Anomalies include congenital amastia, absence of breast tissue, athelia, absence of the nipple, and unilateral breast hypertrophy, with the last being more common. Question. What is the nature of breast secretion in newborns and what causes it? Answer. 90% of newborns have a breast secretion called witch's milk, which is caused by maternal hormones and resolves within 3 to 4 weeks. Question. What is the composition of the breast before puberty? Answer. Before puberty, the breast is primarily made up of dense fibrous stroma and scattered ducts lined with epithelium. Question. When does puberty onset occur in the United States and what are its markers? Answer. Puberty onset in the United States occurs between 9 and 12 years of age, marked by breast development and the growth of pubic hair, with menarche occurring around 11 to 14 years of age. Question. What is prepubertal gynecomastia and how is it defined? Answer. Prepubertal gynecomastia is defined as symmetric breast enlargement in females before 12 years of age, occurring without other pubertal changes. Question. What is the process of Thelarche and how does it occur? Answer. Thelarche, or breast development, is initiated by low-amplitude pulses of pituitary gonadotropins, which lead to increased fat deposition, duct formation, and the appearance of lobular units. Question. What hormones and factors influence breast development? Answer. Breast development is influenced by estrogen, progesterone, adrenal hormones, pituitary hormones, insulin, thyroid hormones, and local growth factors. Question. What is the composition of the mature breast? Answer. The mature breast is composed of fat, stroma, lactiferous ducts, and lobular units. Question. What changes occur in the breast during the menstrual cycle? Answer. The breast epithelium and lobular stroma undergo cyclic stimulation, resulting in hypertrophy and morphological changes. Question. What happens to the breast in the late luteal phase before menstruation? Answer. Fluid accumulates and intralobular edema develops, leading to pain, engorgement, and increased nodularity in the breast. Question. What breast changes occur during pregnancy and lactation? Answer. Pregnancy causes breast enlargement and the formation of new acini. After birth, hormonal changes trigger lactation, and oxytocin stimulates milk expulsion. Question. What happens to the breast during menopause? Answer. Menopause leads to breast involution, which is characterized by increased fat content, decreased connective tissue, and loss of lobular units. Question. How does postmenopausal hormone replacement therapy affect breast tissue? Answer. Hormone replacement therapy after menopause can cause persistence of lobules, hyperplasia of ductal epithelium, cyst formation, and increased breast density. Clinical approach to the breast patient history question. What should be included in the patient history for breast disease? Answer. The patient history for breast disease should include risk factors for breast cancer and symptoms such as mass, pain, discharge, swelling, and skin changes. Question. What should be inquired about in a cancer suspect history for breast patients? Answer. In a cancer suspect history, one should inquire about constitutional symptoms, bone pain, headaches, weight loss, and respiratory changes to evaluate for metastatic disease. Question. What are the risk factors for breast cancer? Answer. The risk factors for breast cancer include demographics, exposure to estrogen, reproductive history, family history of cancer, and prior radiation exposure. Physical examination question. How is a breast examination performed? Answer. A breast examination begins with visual inspection in an upright sitting position, followed by palpation of the breast tissue and regional lymph nodes. Question. What is assessed during the visual inspection of the breast? Answer. During visual inspection, the examiner checks for masses, asymmetries, skin changes such as dimpling or ulceration, nipple changes like retraction or inversion, and signs of Paget disease. Question. What regions should be palpated during a breast examination? Answer. The axillary, Supraclavicular and infraclavicular regions should be palpated to check for enlarged lymph nodes. Question: how is breast palpation performed? Answer: breast palpation is performed with the patient lying supine and the arm above the head, compressing breast tissue towards the chest wall and examining each quadrant and under the nipple. Question: how is a palpable mass assessed during a breast examination? Answer: a palpable mass is assessed based on its size, shape, consistency, location, and mobility to distinguish between benign and malignant lesions. Question: what is the utility of ultrasonography in the breast examination? Answer: ultrasonography is used as an extension of the physical examination to differentiate normal structures from masses and to distinguish cystic from solid lesions. Breast imaging and diagnostic biopsy screening. Mammography. Question: what is the main purpose of screening mammography? Answer: the main purpose of screening mammography is to detect breast cancer in females who do not have symptoms, with the goal of early detection and possibly less aggressive treatment. Question: on what basis is screening eligibility for mammography determined? Answer: screening eligibility for mammography is determined based on a female's lifetime risk of developing breast cancer, which includes factors such as personal and family history, genetic predisposition, and a history of previous chest radiation therapy. Question: what has research shown about the effectiveness of screening mammography in reducing breast cancer mortality? Answer: research from 8 prospective randomized trials has shown that screening mammography reduces deaths from breast cancer by 15% in women aged 39 to 49, 14% in women aged 50 to 59, and 32% in women aged 60 to 69. Question: should mammographic screening be continued in older females who are in good health? Answer: yes. Mammographic screening should be continued in older females who are in good general health and would be considered appropriate candidates for surgery. Question: what are the screening recommendations for females with average risk of breast cancer? Answer: for females considered to have average risk, screening mammography is recommended to begin at age 40 and should be continued every year as long as the patient is a candidate for surgery. Question: what imaging modality is recommended annually for high-risk patients? Answer: annual magnetic resonance imaging is recommended for high-risk patients, including those with a previous history of breast cancer, known pathologic germline mutation, significant family history of the disease, or other risk factors that result in a greater than 20% lifetime risk of breast cancer. Imaging modalities. Mammography. Question: what is the primary imaging modality for screening females without breast symptoms? Answer: mammography, using 2 views, mediolateral oblique and craniocaudal, is the main imaging modality for screening females who do not have breast symptoms. Question: how does diagnostic mammography differ from screening mammography? Answer: diagnostic mammography involves obtaining additional views to further evaluate any abnormalities or clinical findings detected during initial screening. Question: how are mammographic abnormalities assessed for malignancy risk? Answer: mammographic abnormalities, such as microcalcifications and unusual densities, are assessed using the breast imaging reporting and data system scoring system to determine the likelihood of malignancy. Question: what effect does high breast density have on mammographic screening? Answer: high breast density reduces the accuracy of mammography and is also an independent risk factor for developing breast cancer. Question: how do digital mammography and tomosynthesis improve breast cancer detection? Answer: digital mammography and tomosynthesis, also known as three-dimensional mammography, improve image quality and increase the detection of breast cancer compared to traditional film screen mammography. Question: when might supplemental imaging be recommended for females with dense breasts? Answer: supplemental imaging with ultrasound or magnetic resonance imaging may be recommended for women who have dense breasts. Classified as breast imaging reporting and data system categories C and D. Question: what are the advantages and disadvantages of tomosynthesis in breast imaging? Answer: tomosynthesis has the advantage of detecting more breast cancers but is associated with a slightly higher rate of false positives and recalls, as well as a modest increase in radiation dose. Question: what are the benefits of contrast-enhanced mammography? Answer: contrast-enhanced mammography increases the detection of breast cancer, reduces the rate of false positives, and its accuracy approaches that of magnetic resonance imaging. Question: what is the role of contrast-enhanced mammography in surveillance of breast cancer survivors? Answer. A phase 3 clinical trial is currently investigating whether contrast-enhanced mammography can improve screening for females who have previously been diagnosed with breast cancer. Ultrasonography question. What is the utility of ultrasonography in breast cancer diagnosis? Answer. Ultrasonography is useful for characterizing breast lesions, especially in dense breasts, and for guiding biopsy procedures. Question. What are the main limitations of ultrasonography as a screening tool for breast cancer? Answer. The main limitations of ultrasonography are that it depends heavily on the operator's skill, lacks standardized protocols, and has not been shown to reduce mortality from breast cancer. Question. What were the findings of the Akron 6666 trial regarding the use of mammography plus ultrasonography? Answer. The Akron 6666 trial found that using both mammography and ultrasonography detected more cases of breast cancer but also led to an increase in false positives and unnecessary biopsies. Magnetic resonance imaging question. What are the uses of magnetic resonance imaging in evaluating breast abnormalities? Answer. Magnetic resonance imaging is useful for identifying primary breast tumors, assessing the extent of disease, evaluating residual disease after treatment, and screening for cancer in the opposite breast. Question. What is a limitation of magnetic resonance imaging compared to mammography or ultrasonography? Answer. Magnetic resonance imaging has a lower specificity than mammography or ultrasonography because benign and malignant lesions can appear similar on imaging. Question. How sensitive is magnetic resonance imaging for detecting invasive breast cancer and ductal carcinoma in situ? Answer. Magnetic resonance imaging has a sensitivity greater than 90% for detecting invasive breast cancer, but only 60% or less for detecting ductal carcinoma in situ. Question. What is the predictive value of magnetic resonance imaging in breast abnormality detection and what problem does it present? Answer. Magnetic resonance imaging has a high predictive value of 47.9% for detecting breast abnormalities, but more than half of these findings are false positives, which can lead to unnecessary procedures. Question. What did the COMAS trial reveal about reoperation rates in patients who underwent magnetic resonance imaging? Answer. The COMAS trial found no significant difference in reoperation rates between patients who had magnetic resonance imaging and those who did not. Question. What was the contralateral breast cancer detection rate in the COMAS trial compared to other trials? Answer. The COMAS trial reported a significantly lower detection rate of cancer in the opposite breast, 1.6%, compared to other trials. Biopsy fine needle aspiration question. What does the fine needle aspiration procedure involve in breast lesion evaluation? Answer. Fine needle aspiration involves inserting a needle into a breast mass to collect fluid and cells, which are then examined under a microscope for cytologic evaluation. Question. What is a limitation of fine needle aspiration in diagnosing breast cancer? Answer. Fine needle aspiration cannot distinguish between non-invasive and invasive lesions if malignancy is present, so a core needle biopsy is required for a definitive diagnosis. Question. When is fine needle aspiration particularly useful in breast cancer evaluation? Answer. Fine needle aspiration is especially useful for evaluating a second suspicious lesion in a breast with an already known malignancy, and for assessing lymph nodes for metastatic disease, which helps provide prognostic information and guide treatment decisions. Core needle biopsy question. What does the core needle biopsy procedure entail? Answer. Core needle biopsy involves using a needle to extract small tissue samples from breast lesions for examination under the microscope. Question. What guidance methods are available for performing a core needle biopsy of breast lesions? Answer. Core needle biopsy can be performed under the guidance of mammographic imaging, ultrasonography, or magnetic resonance imaging, depending on the characteristics of the breast lesion. Question. What is stereotactic core needle biopsy and how is it performed? Answer. Stereotactic core needle biopsy uses mammographic imaging to accurately target and sample breast lesions, often with the patient lying in a prone position. Excisional biopsy question. What is the preferred minimally invasive diagnostic procedure for breast lesions? Answer. Core needle biopsy is the preferred minimally invasive procedure for diagnosing breast lesions. Question. What are the drawbacks of surgical excisional biopsy in the diagnosis of breast lesions? Answer. Surgical excisional biopsy increases healthcare costs and can delay definitive surgery for patients with breast cancer. Question. What is the discordance rate for core needle biopsy and what does it imply? Answer. less than 10% of core needle biopsy procedures yield inconclusive or discordant results, which sometimes means that surgical excision is still needed for a definite diagnosis. Identification and care of high-risk patients. Risk factors for breast cancer. Question: what are the categories of risk factors for breast cancer? Answer: the categories of risk factors for breast cancer include patient demographics and lifestyle, chest wall radiation, lifetime exposure to estrogen, family and genetic risk factors, personal history of breast cancer, and histologic risk factors. Question: what percentage of postmenopausal breast cancer cases can be attributed to modifiable risk factors? Answer: 30% of postmenopausal breast cancer cases are attributed to potentially modifiable risk factors. Question: why is identification of risk factors important in females? Answer: identification of risk factors is crucial for general health screening in females. Patient demographics and lifestyle. Question: how does age affect breast cancer risk? Answer: breast cancer incidence increases with age, peaking in the 8th decade of life. Question: what is the role of sex in breast cancer risk? Answer: breast cancer primarily affects females, with males accounting for less than 1% of cases. Question: what lifestyle and environmental factors are associated with breast cancer risk? Answer: economic development, shift work, obesity, smoking, alcohol consumption, physical inactivity, and diet are associated with breast cancer risk. Chest wall radiation. Question: how does chest wall radiation impact breast cancer risk? Answer: chest wall radiation results in a 2-fold to 4-fold increased risk of breast cancer in patients with cancers requiring mantle irradiation, especially before age 30. Question: when does the risk of breast cancer start to increase after radiation? Answer: the risk starts to increase approximately 8 years after radiation. Question: what is the recommended age to start breast cancer screening for patients with a history of chest wall radiation? Answer: patients are recommended to start breast cancer screening at 25 to 30 years of age. Hormone exposure. Question: which reproductive factors increase or decrease breast cancer risk? Answer: early menarche, late menopause, nulliparity, and late first childbirth increase breast cancer risk, while breastfeeding and earlier pregnancies decrease it. Question: how does the use of exogenous hormones affect breast cancer risk? Answer: the use of exogenous hormones, such as oral contraceptives and hormone replacement therapy, is associated with a higher risk of breast cancer. Question: what is the impact of reproductive risk factors on individual and population breast cancer risk? Answer: reproductive risk factors have a relatively mild impact on individual breast cancer risk, but they significantly influence breast cancer prevalence in populations. Question: what was the design of the trial assessing hormone replacement therapy effects in postmenopausal women? Answer: the trial was a randomized controlled study assessing the effects of hormone replacement therapy on cancer, cardiovascular disease, and osteoporosis-related fractures in postmenopausal women. Question: what is the relationship between combination hormone replacement therapy and breast cancer risk? Answer: combination hormone replacement therapy increased the risk of breast cancer and was associated with more advanced stage diagnosis. Question: what did meta-analyses reveal about hormone replacement therapy and breast cancer risk? Answer: nearly all types of hormone replacement therapy, except vaginal estrogens, were associated with a higher breast cancer risk, with increased risk for longer use. Family history of breast cancer and genetic risk factors. Question: how does family history affect breast cancer risk? Answer: first-degree relatives of breast cancer patients have a significantly increased risk, especially if the relative had premenopausal and bilateral cancer. Question: what proportion of breast cancer cases are due to genetic and familial factors, and which mutations are most well known? Answer: genetic and familial factors account for about 10% of all breast cancer cases, with BRCA1 and BRCA2 mutations being the most well known. Question: what cancers are associated with BRCA1 and BRCA2 mutations? Answer: BRCA1 and BRCA2 mutations significantly increase the risk of breast, ovarian, pancreatic, prostate, and male breast cancer. Question: what is the frequency of BRCA mutations in the United States population? Answer: the frequency of BRCA mutations is approximately 0.1% in the United States population, with higher rates in certain closed populations due to founder mutations. Question: What is the penetrance of BRCA1 and BRCA2 mutations? Answer. BRCA1 and BRCA2 mutation penetrance is estimated to be 56%, with a confidence interval of 40 to 73%. Question. How do BRCA1-associated breast cancers compare to BRCA2-associated cancers? Answer. BRCA1-associated breast cancers are generally more aggressive than BRCA2-associated cancers. Question. Which other genetic mutations are associated with increased lifetime risk of breast cancer? Answer. PALB2, ATM, CHEK2, and CDH1 mutations are associated with a 20 to over 60% lifetime risk of breast cancer. Question. Do these mutations increase the risk of other cancers besides breast cancer? Answer. Yes. These mutations also increase the lifetime risk of non-breast cancers. Question. How are screening recommendations determined for patients with genetic mutations? Answer. Screening for these patients is based on their individual risk of breast and other cancers, as outlined in the National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology. Personal history of breast cancer and other histologic risk factors. Question. How does a history of breast cancer affect risk for a second primary cancer? Answer. A history of breast cancer increases the risk of a second primary cancer, usually in the other breast. Question. What factors influence the risk of contralateral breast cancer? Answer. Age at first diagnosis, estrogen receptor status, adjuvant treatments, family history, and histologic abnormalities such as lobular carcinoma in situ influence the risk. Question. What is the significance of classic lobular carcinoma in situ as a risk factor? Answer. Classic lobular carcinoma in situ is a histologic marker for increased breast cancer risk, not a cancer precursor itself. Question. How is lobular carcinoma in situ managed? Answer. Management includes a conservative approach with close observation, high-risk screening, and consideration for chemoprevention. Some patients may opt for prophylactic mastectomies. Question. How does breast density affect breast cancer risk? Answer. Dense breasts, classified as Breast Imaging Reporting and Data System C or D, are associated with a 1.5 to 2-fold increased risk of breast cancer compared to non-dense breasts. Question. What is the risk associated with proliferative breast changes with atypia? Answer. Proliferative changes with atypia, such as atypical ductal hyperplasia or atypical lobular hyperplasia, are associated with a 4 to 5 times increased risk of breast cancer compared to the general population. Question. Which risk factors significantly increase breast cancer risk? Answer. Family history of breast cancer and atypical hyperplasia significantly increase the risk. Question. What is the annual risk of breast cancer with atypical ductal hyperplasia or atypical lobular hyperplasia? Answer. The annual risk of breast cancer with atypical ductal hyperplasia or atypical lobular hyperplasia is 0.5 to 1% per year. Question. What are the recommendations for excision of atypical ductal hyperplasia or atypical lobular hyperplasia? Answer. Excision is generally recommended, but observation is possible depending on patient risk factors, disease volume, and biopsy results. Risk assessment. Question. What are the limitations of breast cancer risk assessment models? Answer. Various models exist, each with limitations in incorporating risk factors, potentially leading to inaccurate risk estimation for certain populations. Question. What factors are considered in the Gale model for breast cancer risk assessment? Answer. The Gale model considers factors such as age, race, age at menarche, age at first live birth, number of previous breast biopsies, presence of proliferative disease with atypia, and family history of breast cancer. Question. What are the limitations of the Gale model? Answer. The Gale model may underestimate risk for BRCA1 or BRCA2 mutation carriers, overestimate risk for non-carriers, may be inaccurate for non-European patients, and does not include detailed genetic information. Question. Which models are used for breast cancer risk assessment and what factors do they include? Answer. Several models, including Tyrer-Cuzick, Gale, Claus, Couch, and BRCA-Pro, estimate breast cancer risk based on factors like age, family history, hormonal history, and genetic mutations. Question. What factors does the Tyrer-Cuzick model incorporate? Answer. The Tyrer-Cuzick model incorporates a comprehensive range of risk factors, including age, weight, height, hormonal and reproductive history, BRCA1 or BRCA2 status, breast biopsy history, and detailed family history of breast and ovarian cancer. Question: what is the estimated prevalence of BRCA1 or BRCA2 mutations according to Couch and BRCA-Pro models? Answer: the estimated prevalence of BRCA1 or BRCA2 mutations is approximately 1 in 300 to 500 in the general population. Question: which factors are considered risk factors for breast cancer? Answer: breast density, alcohol consumption, body weight, and physical activity are risk factors for breast cancer. Question: what are the recommendations for genetic testing according to guidelines? Answer: National Comprehensive Cancer Network guidelines recommend genetic testing for specific patients with breast cancer, while the American Society of Breast Surgeons recommends it for any patient with a personal history of breast cancer. Question: what does commercial genetic testing offer? Answer: commercial genetic testing has become more accessible and offers multi-gene panel testing, including BRCA1, BRCA2, and other genes associated with increased breast cancer risk. Question: which additional genes are included in breast cancer genetic testing panels? Answer: additional genes for testing include Abraxas1, AKT1, BRIP1, DICER1, EPCAM, FANCC, FANCM, MRE11, MUTA, PIK3CA, RECQL, RINT1, SDHB, SDHD, and XRCC2. Question: how should genetic testing results be interpreted? Answer: results should be interpreted with patient history and the clinical scenario to determine relevance and potential penetrance of pathogenic mutations. Question: what is the recommendation for individuals with a variant of uncertain significance? Answer: individuals with a variant of uncertain significance should not be acted upon. Care of high-risk patients. Question: how do clinicians manage risk factors for breast cancer? Answer: clinicians assess risk factors, use risk models, and consider individual patient factors to make recommendations about breast cancer screening and prevention. Question: what factors indicate increased risk for breast cancer? Answer: increased risk is indicated by a 5-year calculated risk of 1.66% or higher by the Gale model, a 20% or higher lifetime risk based on histologic, family, and genetic factors, or a history of thoracic radiation between the ages of 10 and 30 years. Question: what is the recommended management for high-risk patients? Answer: management includes close surveillance with clinical breast examination, mammography, and breast magnetic resonance imaging, along with interventions to reduce risk, such as chemoprevention or a bilateral prophylactic mastectomy and salpingo, oophorectomy. Close surveillance. Question: on what basis were surveillance guidelines for high-risk individuals established? Answer: guidelines were established in 2002, based on expert opinion rather than prospective trials. Question: what are the imaging recommendations for high-risk individuals? Answer: annual tomosynthesis is recommended starting from the diagnosis of the histologic risk factor, 10 years earlier than the youngest family member affected by breast cancer, or 8 years after receiving thoracic radiation therapy, but not before age 30. Question: who should receive magnetic resonance imaging screening for breast cancer? Answer: magnetic resonance imaging screening is recommended as an adjunct to annual mammography for females at high lifetime risk for breast cancer, including those with a history of radiation to the chest at age 10 to 30, a known genetic mutation with increased risk for breast cancer, or a lifetime risk of approximately 20 to 25% or greater. Chemoprevention of breast cancer. Question: which drugs are used to reduce breast cancer risk? Answer: selective estrogen receptor modulators and aromatase inhibitors are used to reduce breast cancer risk. Question: what is the role of tamoxifen in chemoprevention? Answer: tamoxifen is approved by the United States Food and Drug Administration for reducing breast cancer risk in high-risk patients based on the National Surgical Adjuvant Breast and Bowel Project P1 trial. Question: what are the efficacy and side effects of tamoxifen? Answer: tamoxifen reduced invasive breast cancer risk by 43% in a 7-year follow-up, but increased the risk of endometrial cancer and pulmonary embolism. Question: what were the outcomes of tamoxifen prevention trials? Answer: 3 trials, Italian, Royal Marsden, and International Breast Cancer Intervention Study I, showed varying results, with International Breast Cancer Intervention Study I confirming a 32% risk reduction in breast cancer incidence. Question: what did meta-analyses of tamoxifen trials confirm? Answer: Meta-analyses confirmed a 38% reduction in breast cancer risk with tamoxifen, along with increased risks of endometrial cancer and venous thromboembolic events. Question: how does raloxifene compare to tamoxifen in breast cancer prevention? Answer: raloxifene was less effective than tamoxifen in reducing breast cancer risk but had a better toxicity profile. Question: what was the finding of the multiple outcomes of raloxifene evaluation trial regarding breast cancer risk? Answer: the multiple outcomes of raloxifene evaluation trial showed a 54% reduction in breast cancer incidence with raloxifene. Question: what is the effect of exemestane on breast cancer risk? Answer: exemestane significantly reduced the incidence of invasive breast cancer in high-risk postmenopausal women. Question: what trial evaluated the effectiveness of anastrozole for breast cancer prevention? Answer: anastrozole was evaluated in a similar trial to exemestane, targeting high-risk individuals with a family history of breast cancer or a personal history of ductal carcinoma in situ or lobular carcinoma in situ. Question: how effective is anastrozole in reducing breast cancer incidence? Answer: anastrozole reduces breast cancer incidence by 53%. Question: what should be done for patients with a high risk of breast cancer? Answer: patients with a high risk of breast cancer should be individually counseled. Question: what are the options for chemoprevention of breast cancer? Answer: chemopreventive drugs should be suggested based on individual factors, with reduced dose tamoxifen as an option for some patients. Prophylactic mastectomy. Question: how effective is bilateral prophylactic mastectomy in reducing breast cancer risk? Answer: bilateral prophylactic mastectomy reduces breast cancer risk by 90% in high-risk females. Question: what risk-reducing interventions are recommended for BRCA mutation carriers? Answer: prophylactic mastectomy and salpingo-oophorectomy are recommended for BRCA mutation carriers to reduce risk. Question: are risk-reducing surgeries considered for non-BRCA mutation carriers? Answer: risk-reducing surgery is considered on a case-by-case basis for non-BRCA mutation carriers due to limited data. Question: who should be recommended for contralateral prophylactic mastectomy among mutation carriers? Answer: contralateral prophylactic mastectomy is recommended for females with primary breast cancer who are mutation carriers. Question: what is the trend in contralateral prophylactic mastectomy among non-mutation carriers? Answer: more females with newly diagnosed breast cancer are choosing contralateral prophylactic mastectomy to reduce the risk of contralateral breast cancer. Question: for which patients is contralateral prophylactic mastectomy not recommended? Answer: contralateral prophylactic mastectomy is not recommended for average-risk females with unilateral breast cancer, those with advanced primary cancer, those with high risk for postoperative complications, BRCA-negative patients in BRCA-positive families, and males with breast cancer. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.